Based in Lancaster, Pennsylvania, USA, Medtrition is a global supplier of medical food products that effectively address challenging medical conditions that are dealt with on a daily basis. All of our products are clinically supported and provide cost-effective solutions to address over 20 common conditions, which include wound healing, constipation, diarrhea, dysphagia, oncology, ICU, renal and hepatic diseases, chronic protein malnutrition, and urinary tract infections. At Medtrition, our mission is simple. We help people feel better by providing evidence-based nutritional interventions that improve patient outcomes.
Good afternoon, everyone, and a warm welcome from the entire Pharmaco and Medtrition team. For the ones that don't know me, my name is Laura, so I'm the product manager for Medtrition in South Africa, and I'd like to thank you so much for taking the time to join us today. But before we get started, it would be lovely to see where everybody is joining us from today. So if you don't mind entering your location, that would be lovely to see. I see we've got some people from PE, Bloem, Durban, Joburg, so all over the country. Not sure where is home. USA, welcome. We've got a lot from Joburg. Natal and Western Cape is coming through. Rustenburg. Yeah, it seems like majority is here joining from our local base, Joburg. Botswana and the Northern Cape guys. Welcome everyone. Thank you, East London. Welcome everyone. It's lovely to see that everybody is joining from all over and even from other countries as well. I know the guys from America, it's still very early there on your side, so thank you for taking the time to join us early morning. Yeah, so it's lovely to have all of you here, and I hope you'll have a lovely afternoon with us. As you know, all the research are indicating towards more higher protein, and that is also why we felt with this webinar we'd like to focus more on not just why there is a higher need for protein, but also how we can actually practically bridge that protein gap. And who better to talk to us or guide us through that discussion than our dietitian, Vanessa Kotze. So Vanessa has worked over 12 years at the University of Pretoria as a lecturer. She is also a Triple L teacher. She's been the SASPIN president for over 3 years and still on the executive board, while she's also running her own private practice. So with both her academic knowledge and then also her practical experience, I thought that it'd be wonderful for us to get her practical insights into this interesting topic. So thank you so much for all your time and efforts, Vanessa, and good luck for the presentation. We look forward to hearing what you can share with us.
Thank you for the introduction, Laura. And thank you to Medtrition for the opportunity to share some of the knowledge and the experience I've gained working in practice. I also want to state explicitly that a lot of the practical things will be my personal experience in my practice. As you will see, there isn't a lot of information always on specifically the protein pulsing. but I did try to get some information for you, and the references are at the end of my presentation. So you're more than welcome then to go look on PubMed or Google Scholar at the literature. So I would like to start first off with why is protein important, well, for the general healthy population, but then specifically for critical ill patients. So if you go look at the WHO recommendations for 30 to 60-year-old females and males, the average is 44 kilocalories per kilogram per day for males, and the variance is 35 to 53 kilocalories per kilogram. For women, it's 36 kilocalories per kilogram per day, and the variance is 29 to 44 kilocalories per kilogram. And the little bit of protein that they mention just states 0.75 grams per kilogram per day to avoid starvation. Okay, so this is not for protein synthesis. But the little bit that we do know actually started with something called the Minnesota study. And I don't know if you have ever heard of this. So the Minnesota study, I love history, so I always go back a few years. And at the end of the Second World War, the US soldiers were liberating European cities, and they actually found emaciated and cachectic and starved civilians, and they actually didn't know how to treat these patients. So the medics that were with the teams, they didn't know. And Dr. Ansel Keys was a young physiology professor at the University of Minnesota, but he was also a consultant to the War Department. And he actually drew up this study, which nowadays will not get ethical approval, where they actually wanted to go look at how humans would be affected by physiological and psychologically a limited diet. And then also how to see how to rehabilitate these humans once they've gone through this starvation period. So they drafted 36 healthy male adults. So these were adults that actually weren't in the war. They refused to participate in the war. They got 100 applicants, but they only did a lot of screening, and they selected 36 healthy male adults. The average weight was 70 kilograms. And please do remember that at this time, you didn't have overweight and obese adults most of the times. And what they did is they had a baseline period that was 3 months long. And during this 3 months, they got a diet of 3,200 kilocalories per day. But these healthy males were also quite physically active as well. So looking at both components. So after the 3 months, they went into the starvation period. So that's actually the trial period. So they planned a 6-month semi-starvation period where they actually took down the energy to 1,800 kilocalories per day. So that was more or less 23 kilocalories per kilogram per day for these males that were up to this point taking about 50 kilocalories per kilogram per day. And then also what happened with the protein, they were probably looking at around about a 0.7 grams per kilogram protein per day intake. And they planned to keep the participants on this diet for 6 months. But into the study, probably about a month or so into the study, they actually realized, listen here, this is not working because the the participants are losing so much weight. So they were planning on them losing a kilogram a week, but they actually lost a lot more. So they decided to increase the energy intake to 30 kilocalories per kilogram per day, and the protein to a minimum of 0.9 grams per kilogram per day. And what they actually saw at the end of the 6-month period was an average weight of 52 kilograms. So that is down from the 70 to the 52. So I think what is actually more important, as I've put a question mark there, is actually to go look at the effect on the participants of the starvation period. So what they saw was the extremely rapid weight loss, specifically on the early phase. Then also they actually saw significant edema from the protein energy malnutrition. They saw a remarkable decline in strength and energy. So they did what they call the backlift dynamometer, and they saw a 20% decline over the 6 months. They saw significant depression, anxiety, and neurological deficits. So they actually had one participant that lied about what he was eating. So they were allowed to get almost like a takeout so they could go out. And then at the sessions, this participant would just actually go to restaurants and eat as much as he wants to. And when he comes back, he lies about it. So when they confronted him about it, he actually got quite aggressive and he had to be admitted to a hospital. So as soon as they rehabilitated this participant, he actually was fine. So it really had neurological implications for the participants. So the average heart rate of the patient slowed dramatically. It slowed from 55 beats per minute to 35 beats per minute. The blood volume dropped by 10%, and they had a decrease in their heart size as well. So after the 6 months, what we call the nutritional rehabilitation phase, that was a 3-month period. And here what they administered them was a 1,800 kilocalories per day, but then they split them into 4 groups. So the one group got a 400 kilocalories per day, the other group an additional 800 on top of the 1,800, the third group an additional 1,200 on top of the 1,800, and the fourth group of 1,600 on top of the 1,800. And then later on, they actually gave even an additional 800 kilocalories on top of that as well. And what they saw is it took some of the participants 6 months to 2 years to actually regain the weight that they have lost. So if we now look at the WHO and in the Minnesota study, so at baseline, these participants were eating 50 kilocalories per kilogram per day. During the semi-starvation period, it went down to 23 to 30 kilocalories per kilogram per day, and the protein ranged from 0.7 up to 0.9 grams per kilogram protein per day. And the rehabilitation went up, the phase went up to 60 kilocalories per kilogram per day to actually let them regain the weight that they've lost. So the thing is, what happens in critically ill patients if that happened in healthy patients? So if you look at critically ill patients and the necessity for protein, so we know for us as healthy individuals, protein is not an energy source, but during critical illness, it does become a substrate for energy. And the thing is, we don't have any reserves because the protein that we do have in our body has actually got a structural or functional purpose. So for example, during critical illness, it's got the function of gluconeogenesis. It's used for protein synthesis, so your acute phase proteins like the CRP, and then also substrates for immune cells. So you need a strong immune system. So what we see during this time is that we see actually accelerated muscle protein breakdown. So they've observed a 59% decrease in free amino acids at the muscle, as well as a 72% decrease in glutamine at the muscle. And what we see is that this proteolysis that's observed results in a loss of lean body mass, and then this can result in ICU-acquired weakness. And the proteolysis is mostly driven by your hormone and cytokine-mediated responses, but we also know that it's enhanced by sedation, so any of your medication that's administered for sedation, as well as mechanical ventilation also contributes to it. And what they've seen as in ICU patients is that they've got an increased 4-fold protein losses in the first 24 hours of admission. So that's actually quite a bit. So for the first 10 days in ICU, you can see up to a 10% loss of lean body mass, or some references also mention a kilogram per day loss of lean body mass. And we know that this 10% actually results in decreased immunity, and the immune system is actually quite important for your critically ill patients. One reference even mentioned that a 30% drop in the quadriceps skeletal muscle mass was also observed. Then if you go to 20% loss of lean body mass, you've got decreased wound healing and increased muscle weakness that is observed. So the thing is, okay, so we realize that you are losing lean body mass and you're going to lose weight as well as a result of it. But how does it affect your outcomes if it does? So looking at some of the studies, you can see short term, and this is where they look at a 30 and 60-day mortality. We actually see an increase in the mortality rate if a patient loses this lean body mass or they become malnourished. And you also see an increased days of ventilator days. If you look at long term, so this is now where they start looking at 90-day or the 265, so almost a year a day, post-discharge mortality in patients. So the patients that were at risk for malnutrition, their odds ratio was 1.77. So this means 1.77 at 90 days. It tells you that it's almost double what a well-nourished patient, the risk to be readmitted for mortality, my apologies. Where for the 265-day post-discharge, the odds ratio was 1.14. So if you look at non-specific malnutrition, the odds ratio, so the possibility of passing away 90 days post-discharge, was 2.51, so it's actually very high. And then for 265 days post-discharge, it was 1.7. And then if you go look at protein energy malnutrition, just look at that odds ratio there. It's 3.72 and then 3.75 for the 265. So you've got an extremely high risk of increased mortality if you're malnourished on discharge from the ICU or then from the hospital. So what they also see is a loss of independence, a delayed ability to return to work, and an increased reliance on healthcare. And in the UK, they actually went to go look at how much it costs the government to support patients that were malnourished. And they saw that the increased cost was £7.3 billion per annum. 3.8 billion of that was treating malnourished patients in hospital, and then 2.6 billion for long-term facility treatments. So I think looking at all this evidence, we really do see that protein is quite important. We can't debate that. But what is debatable is the optimal intake timing for protein administration for our patients in ICU or then in the hospital. So this is the references I used here was mostly by Dresden of a 2021 article and Sue for 2021 as well. And they went to go look at the timings that we have. So if you first go look at the recommendations we have, so remember we've got the acute phase where we usually see the EP phase for the first 24 to 48 hours, and they call this the initial phase. And here the literature really states that the recommendations are 70% of your requirements should be administered at that stage. And we'll look at why we say that just now. So then for your flow phase, that's also part of the acute phase. The aspirin recommendations are 1.2 to 2 grams per kilogram per day protein, and the aspirin guidelines are 1.3 grams per kilogram per day protein. And then if you go look at the recovery phase, you can actually go up to 1.5 to 2.5 grams per kilogram per day. So if you look at that initial stage where we say you only need 70% of the requirements, now we need to go look at why do we say that. So they think that the reason for this is that the patients at this stage experience vasoconstriction and hypermetabolism. So they actually don't utilize the nutrients that well. And what they've seen is, so initially they hypothesized, but listen, we need to give high protein right from the start. So even during this EP phase, we need to give high protein. And they looked at a study and they actually found no difference in mortality, length of stay in the ICU, hospital length of stay, or duration of mechanical ventilation in the patients. And I think part of this is due to the fact that if you administer this high protein levels, you've got increased autophagy. It suppresses autophagy. So autophagy is a way of the body to get rid of any organelles that were damaged. And if you suppress that, it's actually detrimental to the body. And then also what they found is that they actually think that because of the proteolysis that you've got during this phase, you've got this increased amino acid levels during the critical illness, and that stimulates the glucagon and resulting in more hepatic amino acid breakdown and ureagenesis. So it actually drives this whole process. So if you go look at the following phase, so the flow phase, so here what you generally see in our patients is an improved insulin sensitivity. And this actually results in the patient being able to utilize the exogenous substrates a lot better than what they could do in the initial stage. And this is probably really the time where we need to go look at administering high protein medical nutrition therapy to our patients to help reduce the proteolysis. But again, also a lot of studies now, well, not a lot of studies, but some evidence coming out that you actually really need to look at physical rehabilitation as well during this time. Then if you go into the recovery phase, so some patients will either recover or they will get PICS. Okay, so this is this chronic illness that they'll develop. And we don't have a lot of information on what to do here. But if you go look at what happened in the Minnesota study, the hypothesis is that we probably need about 1.5 to 2.5 grams of protein per kilogram per day for patients to recover during this stage, and for energy about 47 to 59 kilocalories per kilogram per day, which is in line with the Minnesota study. But what they also hypothesize is that the average post-ICU patients is usually quite old and frail. Okay, so we tend to see more of our elderly population in the ICUs. So one can maybe assume a higher anabolic threshold for protein synthesis. So they're quite anabolic resistant, and that you actually might need a bit more protein due to that effect as well. So this is just looking at what is currently happening in the patient, but what about what happened beforehand? So does the nutritional status of a patient actually affect how they're going to react to the protein supplementation? So Lloyd et al. Conducted a study, and it's quite recent, but they conducted it in 2016 and was only published now recently in 2020, where they went to go look at determining the association between early protein intake and mortality and critically ill ICU patients. But one group of patients with normal skeletal muscle area, another group with low skeletal muscle area, and then a third group with combined low skeletal muscle area and density. And the percentages in brackets actually tell you what a percentage of those patients, and it was about just over 400 patients that were included, actually had normal skeletal muscle area. So that was about 40%, 60% at low skeletal muscle area, and then of that 60%, 200 at the combined low skeletal muscle area and density. So what they did in the study is on day 2 and 4, so remember that's where you go over from the ebb to the flow phase, they administered 1.2 to 1.5 grams per kilogram per day. And what they saw is in the group with a normal skeletal muscle area, they saw no significant associations between the amount of protein administered and the outcomes. But in the two groups with the low skeletal muscle area, as well as the one with the low skeletal muscle area and density, they saw a decrease in the 60-day and the 6-month mortality rates. So it does seem that you really need to consider giving higher protein to your malnourished patients. And the reason for that is most probably that they do not have any reserves. So what happens with the people in the ebb phase is that you've got your own endogenous reserves. So you've got a breakdown of the protein and of your fat stores. But in malnourished patients do not have that. So they don't generate their own endogenous substrates. So I've got a question for the audience. So the question is, what is more important in critically ill patients? Adequate energy administration or adequate protein administration, or both equally important? And I'll just give you a minute or so. Please just go put in the comments section your answer. And it's just for discussion. So I see that most of you feel that both energy and protein administration is important in your critically ill patients. Then 40% of you, okay, now it's a little bit down, feels that protein administration itself is important, and then nobody feels that energy alone is important. Okay, so I'm happy about those results. So if we go look at the evidence of what they say with regards to protein versus energy or both. Sorry, let's just quickly give it time that more people answer. I see people are still busy. Okay. Okay, I think we can move on so that I can continue with the presentation. So what they have found is that in some studies they actually found that protein is the most important, more important than energy. So Alberta et al. In 2009 conducted a survey looking at dietetic practices and the administration of feeds. And what they found was that the delivery of additional non-protein calories does not significantly improve the nitrogen balance in illness beyond the delivery of 50% of the prescribed resting energy expenditure. So what it tells us is it doesn't help giving a lot more energy. It's not going to improve your nitrogen balance. But if you look at a study conducted by Nicolo, they actually went to go look at a patient outcome meets on day 60. So they looked at the mortality on day 60. So they went to go look at, are we meeting the energy/protein requirements on day 4 and on day 12? And what they actually found is that you had an insignificant improvement in the 60-day mortality when you met the protein requirements. Not so much when you just met the energy requirements or meeting the energy requirements. And then Morgensen actually saw that with your protein deficiency, the odds ratio was 2.2 compared to the energy deficiency of 1.17 with your 30-day mortality rate. So this means that if you don't meet the protein requirements, the odds of you passing away at 30 days is twice as likely as somebody where they actually meet or where they're energy deficient. So it really is important to make sure that you meet all the protein requirements. So we've discussed now, we definitely know that protein is quite important in our patients, but the question is there a gap? Okay, so is there a difference between what is happening compared to what we are prescribing? And again, there's 1 or 2 studies that were conducted that looked into this. So again, Alberta et al. In 2009 actually found in the first 2 weeks of ICU stay that the administration was only 0.6 grams per kilogram per day. This was a third to a half of the requirements that were prescribed by dietitians. Then Aranukala Murthy in 2021 conducted a survey in Australia and New Zealand where they actually found that the actual protein administration resulted in 0.88 grams per kilogram per day compared to the prescribed 1.46 average. Okay, so it's a huge difference compared to what's happening compared to what was actually prescribed. And then there was an international nutrition survey in 2018 that found that only 55% of the prescribed protein was actually being administered in patients. So I think, all 3 of these studies actually really do show you that there's a huge gap between what protein requirements or what is prescribed and what is actually being administered to patients. So I think the thing as well is to really look at practically bridging this gap. Okay, so theoretically we can look at all these studies, but how do we actually go implement this in our ICUs or in our hospital to make sure that we actually do meet the patient's protein requirements? So I'm going to do this at the hand of a case study. So there's actually one of my patients that's still in the hospital. So this is a 67-year-old female. She came into the hospital with a fractured right femur, and it was actually an emergency procedure they had to do. And during this procedure, she actually developed respiratory distress and she ended up in the ICU. With a nutritional assessment, we found that her BMI to be 21.48. Okay, so that's normal according to the WHO criteria. But the patient reported that she lost 50 kilograms in the past year. Okay. Whether that is accurate is quite questionable, but the weight loss is definitely evident. And in part, we thought that was due to alcohol intake. But also the patient, when I asked her about it, she said, no, she was really stressed and she didn't want to eat prior to being admitted for the procedure. So she reported a very poor intake for 3 to 4 months prior to the procedure. So during her ICU stay, she was administered initially propofol at 5 ml an hour. So we all know that it's a high omega-6 containing emulsion, and that it gives us about 1.1 kilocal per milliliter of energy that we need to take into consideration. If you look at her lab results, her albumin was quite low, not surprisingly, it was 24. And then her UC and E, the potassium was on the lower end of normal, and she had very low urea and creatinine stores as well. So This is from an article by Van Zanten, a 2021 article, and I thought it was a very nice article because it really takes you through the steps on how to calculate and get to how you're going to administer protein boluses. So the first step is to calculate the caloric need by your preferred equation. So whether you would like to use ESPEN or ASPEN, or any of your Aris Benedict or Mifflin St. George, and then to target 70% for the first week. Or then to measure the energy expenditure by indirect calorimetry, which I know a few of us has got in the hospitals, and then set this at 100% of the targets. And they've got a little bit of a rationale there as well. And we know that the overfeeding, specifically during the ebb phase, is detrimental. So it's going to increase the mortality and morbidity of our patients. And the early endogenous energy production cannot be inhibited by feeding. So that's going to happen. It's a natural process that's going to happen. So we need to let that run its course as well. So I calculated this patient's requirements using 25 kilocalories per kilogram, got to 1,375 kilocalories, and 70% of that is 962 kilocalories. Her protein, I calculated at 1 grams per kilogram per day, resulted in 55, not kilograms, grams, my apology. And then the food I calculated 1 milliliter per kilocal, which was just over a liter that you could get per day. So the second step in this process is to subtract, sorry, I just quickly want to see here, is to subtract the amount of non-nutritional calories from propofol, glucose, and citrates from the total energy you've calculated. Remember, you do need to take that into consideration. You could see that the propofol is quite energy dense. And the reason for that is that you, again, don't want to overfeed the patients, specifically now in the initial phases. So what I got at the end is I calculated the propofol. So what I do in my practice, I look at when I assess the patient, I look at the rate that the propofol is running at, and I use that then and multiply it by 24 to get to a daily intake of energy. So the propofol at 5 mils an hour results in 231 kilocalories per day, and I subtracted that from my 70% energy. So that resulted in a 731 kilocalories that I could administer to this patient from the feeds. The protein I kept at 1 grams, and the fluid is still the same. So if you go look at step 3 is to calculate the daily limit for overfeeding. So the maximum amount of calories that you would like to give, just to help you so that you know how you're going to progress with the feeds. And the maximum dose that I decided on for this patient was 25 kilocalories per kilogram. And that is then, like I mentioned earlier, the 1,375 kilocalories. So the range is for her feeds is 731 to 1,375 kilocalories. The protein is 1 gram per kilogram, and the fluid is 1 milliliter per kilocal. So my second question to everybody attending today is, how would you meet the patient's requirements, taking into consideration the history and the calculations that I've done? Would you select a hypercaloric, high-protein polymeric feed? Would you select a hypercaloric, high-protein semi-elemental feed? Or number C, would you select a low or moderate fat, high-protein feed to compensate for the fat that's being administered with the propofol? Or then D, select an isocaloric polyremic feed with additional protein supplementation. So again, I'll just give you a minute to just reply. Okay. So the majority of participants here states that they'll use an isocaloric polymeric feed with additional protein supplementation. And then some said they'll do the low or moderate fat, high protein feed to accommodate the propofol that's being administered. And then a small percentage said they'll select a hypercaloric, high protein, semi-elemental feed. Okay. I think we can just move on to the presentation. Good. Okay. So what the next step is, according to Van Zanten, what they would recommend is that you actually select an appropriate, very high protein to energy ratio enteral feed, or the highest protein energy ratio feed available, and then calculate the maximum acceptable dose based on step 3 without overfeeding. So what I did is, which is a bit different from what most of you said you would do, is I actually decided on a high protein, high energy semi-elemental feed. And over the 3 days, initially I started very slow due to the risk of refeeding because of the history of the poor intake and the weight loss. I also administered thiamine, and then also I love doing vitamins as well. It's an easy product for multivitamin to administer for the patients. And then over the 3 days, I actually built it up so I could get to the requirements as calculated. So you'll see there at day 3, I met 100% of the protein that I calculated, the 1 grams per kilogram, and then also looking at the 20 kilocalories per kilogram. Just remember, initially on day 1 to day 3, as mentioned, you really don't want to give excessively high protein requirements, of course, except in a malnourished patient. And again, I think this is where there's a bit of a gray area, because how are you going to manage this with your patients, specifically this patient that's malnourished? So I do not think there's anything wrong with saying you're going to do a higher protein. I decided on day 4 to really start increasing my protein requirements and rather do a bit of an adjustment with a gradual increase over the 3 days. There's also some evidence with refeeding that you shouldn't be administering excessive amounts of protein either. So, taking that into consideration, I did a bit of lower, but I think one just has to weigh everything up that you're going to decide on how on applying with your patients. So looking at polymeric versus semi-elemental, which one you should use. So the hypothesis is that providing dietary protein as a free amino acid or oligopeptide, so selecting a semi-elemental, will result in increased amino acid availability in the circulation for peripheral tissues and health. However, there's no indications in any of the studies ever conducted that it does result in better outcomes and better tolerance. What they've actually seen in some studies is that you've got worse tolerance and that they really battle to achieve their target protein that they would like to administer. So currently, if you go look at the aspirin and the aspirin recommendations, they're going to they're going to state that they do not recommend the routine use of semi-elemental formulations. So if we move over to day 4 now, so this is where I decided to start increasing the protein a bit. She passed the soft bowel movement. She's still on the semi-elemental at this stage. And her albumin was 25. Her urine creatinine still quite low. Until this day, it is still very low. And her total fluid management at this stage was 80 mils an hour. So I calculated her requirements at the 25 kilocalories per kilogram per day, so 1,375. And I calculated her protein at 1.2 grams per kilogram per day. And that resulted in 66 grams of protein per day. But needless to say, and I think that is where most of you have already considered the nutritional status with the previous question that we had, is of course looking at malnourished patients and they need the higher protein requirements. So I then recalculated and looked at 1.3 to 2 grams per kilogram per day, and that resulted then in 71.5 to 110 grams of protein per day instead of the 55 that we had initially. And I think the thing as well is to consider, so I know she gets physio, or I knew at that stage she was getting physio sessions twice a day, and they stopped the feeds for the physio sessions. She's got, she had to go for x-rays as well. So then they also stopped the feed. So there's a lot of interruptions in the feed administration as well that you need to take into consideration. So I've got 4 questions. So this is the 3rd question. How would you meet the patient's increased requirements as I have calculated it now? Will you just increase if you decided on a semi-elemental feed, would you just increase that rate? Or would you select a very high protein to caloric ratio semi-elemental bag? Will you select a high protein, high energy polymeric feed? Or will you now at this stage start adding a bolus protein supplement to the current feed? I'll again just give you a minute so we can see what you think about it. Okay. So most of you say that you will actually start adding a protein supplement or bolus to the current feeding regimen. And then we've got a variety of answers. Some say they'll select a high protein, high caloric polymeric feed. And then some said, then some at the other options as well. Okay. So the majority is adding protein boluses currently, or then selecting a high protein, high caloric polymeric feed. Okay. So if we can maybe go back to my presentation. Okay. So what they recommend, what Van Zanten et al. Recommend, is that the next step, you actually monitor the actual intake during the day and progress to higher than calculated infusion rates for limited time in case of previous interruptions of administration, and use volume-based strategies. Okay, so in my practice, I don't use volume-based strategies. I just find that it's going to be extremely difficult for my nursing staff to recalculate, take into consideration the hourly amount of fluid they're allowed to do. So for me, it's a bit difficult. I don't know if there's anybody, you can maybe put it in the comment section, whether there's anybody that actually do volume-based strategies in their unit. But so if you go look at high protein caloric feed, so a lot of you said that you'll do that as well. Van Zanten in 2018 actually conducted a study where they took a very high protein to energy ratio polymeric enteral feed and compared it with an isocaloric standard high protein product. And what they found was that the difference between the 2 groups where they administered the very high protein to energy feed was 1.5 grams of protein per kilogram per day compared to the isocaloric high protein product, which only resulted in 0.75. So that is double the amount of protein that you're getting if you use this very high protein to energy ratios. And they actually saw significant higher amino acid concentration in the blood as well. So the recommendation from their side during this study was that it's extremely difficult just to use a high energy, high protein feed. You really need to move over to that very high protein to energy ratio polymeric feeds. But then they also recommend that you actually at this stage maybe consider going over to bolus feeds. So either one of those 2 options are right, or not right, but it's maybe more applicable according to the literature, is that you actually either look at this very high protein to energy ratio polymeric feed, or then looking at adding the protein boluses, which most of you have indicated you would have done. So looking at the day 4 requirements, like I told you, I've recalculated it. And what I've decided is to continue with the same feed at that stage, and then to add boluses as well. But I'll show that to you now. So the possible challenges that I found with any of those options that I presented to you was just taking the current feed and increasing the feed rate, is that a lot of the times you might exceed the volume allowed for the patient. So in my unit, I really try to leave some space, if I can put it like that, for my nurses to administer IV fluids and to administer medication. So I really try to use it as concentrated feed as possible. And then also just using the same feed and increasing the feed rate, you do run the risk of overfeeding on the energy. So I don't think that's the most feasible option. Changing to a polymeric feed, of course, the literature says start with a polymeric feed, not with a semi-elemental. But specifically with this patient, sometimes tolerance can be a problem. She's got a very sensitive GIT, which we only found out later. But I think for any patient, one's also sometimes worried about tolerance. And then also, again, thinking about that amino acid availability in the circulation, there is some evidence that you do have increased amino acids in the circulation if you administer a semi-elemental feed. And then looking at the very high protein to energy ratio feeds is, of course, the availability of these feeds. So not all the units or all the hospitals have got it available. And one needs to go look at the effect on what we call MPS, so it's the muscle protein synthesis. So administering this continuously. So what they recommend is that you add a protein supplement in the case where you feel you're not meeting your protein requirements. But again, explicitly not to give any protein boluses in the first day or first 1 to 3 days post-admission. So if you look at protein pulsing, the question is, what is it actually? So it's administering protein as intermittent boluses. And the possible benefits is that it actually stimulates your muscle protein synthesis a lot more than what continuous feeds does. So with intermittent feeds, with the cyclic administration of amino acids, they actually see a cyclic surge in the amino acid levels in the blood as well as the insulin levels. And they hypothesize that you actually see better muscle protein synthesis because of that. So this really comes out of the sports field. So on the right in the little figure, you're going to see the top figures where you only do this protein pulsing. So you give intermittently a protein bolus. So if you can look at some of the literature, they recommend 21 to 28 grams of protein per bolus. And this comes from clinical studies that have been conducted. But then also looking at continuous feeds, they actually hypothesize that you get this muscle full effect. So when you start the feed initially, or maybe you increase the rate, you get this muscle protein synthesis, but thereafter it's saturated. So you're not going to get an additional muscle protein synthesis if you continue with continuous administration. But again, considering the possible effects of mobilization, so you're going to see at the bottom part of this figure, you can see that the surge is a lot higher. And this is what they recommend is that, mobilization actually does play a role. But then thinking about it, you have to go think about the coordination. So doing the mobilization along with this protein administration. So going back to the case study, like I said, I continued with the semi-elemental feed in this case, and I decided to add ProSource TF3 1 sachet twice a day to meet her protein requirements. So I got to 108 grams of protein per day, and the energy level was 27 kilocalories per kilogram per day. So we're going to go over to the more practical side. So using ProSource in your unit, we've got the ProSource TF3, which I use a lot for tube feeding. You also get the ProSource no carb. That's mostly done for oral consumption because you've got the berry punch flavor. But in our unit, if we run out of ProSource TF3, then we'll switch to the no carb because at least it's got the same amount of protein. It's got 15 grams of protein per serving. And then you also have the ProSource protein powder oral consumption. And this is also meant for you mix it with water and the patient can drink it. So I'm going to hand over. We've got a short clip for you on how we administer ProSource in our unit in the hospital.
The internal feedings, usually we do the internal feedings, it's via the NG, it's via the peg tube. In this case, it's via the peg tube. In the case, because he's got a trachea, he had a CVI previously, he couldn't swallow it all. So the best way to give the feedings is via the peg tube, which is in the stomach. So we are going to start the procedure. The tubing must be always clamped. After giving the tubing, you have to clamp it all the time. Make sure that it's closed. Try to be sterile as much as you can. I'm going to use my sterile paper just to put underneath to make sure that it is sterile, because he's getting food. He needs to get sterile food really. Put your sterile gloves. If you don't have the sterile gloves, you can still use normal gloves. But to be safe, just use the sterile gloves. Okay, always make sure that I just wipe the side first, because it was under the blankets, just to prevent any bacteria. Just wipe that side first before doing anything. And then we are going to use the syringe to give us the feeds. I always have my gauzes with me to just wipe off. Okay. And then I'm going to flush with 30 ml of water, just clean water. Just push it. Make sure it's clamped, and then you open. You put your syringe in. You unclamp. Push it very slow. You don't need to make it fast, just to make the patient comfortable. Otherwise, it's going to be so uncomfortable if you flush it too fast. And when you finish, you don't push until the last drop. Otherwise, you're going to introduce the air bubbles. Then you clamp again, or remove your syringe, and you close. We are going to keep your feed sterile. Just try to use the pack as it is. Don't pour it to something else, otherwise you're going to introduce the bacteria. I'm only going to give 30 ml in this case. Make sure you take up the air again. We don't want to introduce that to him. Still is clamped, opened. Put your syringe, get your tube straight and clamp, and push it slow. Make sure you don't introduce any air bubbles. Okay, there you go. You clamped again. Make sure it's clamped. Remove your syringe and close. Now we are going to give another 30 ml of water, because we have to rinse the fish from the tube. Otherwise, the tube is going to block. If you need medication or the feed via the tube. So I'm going to give another 30 ml of water. Take out of the bubbles. Still clamped there. Open. Put your syringe and clamp. Make sure the tubing is up straight and push it slow. bubbles, preventing the air to just introduce to the stomach. Clamped again, remove and close. Another alternative when giving the feeds, still clamped, you clean and do everything as I did the first time. You just put your syringe in, the tube must be up, and then you give the water first, that 30 ml of water before giving the feed, and then you can just pour your feed in there while it's still clamped, and then unclamp, and then you just go as it is. Okay, just make sure you don't introduce any other ones.
Zoleka, what is the benefits of doing it in the second way?
The second way, you can control the amount of the feeds that are going. There is no way that you are going to push it fast. It's going to run as smooth as it can. Than the syringe, because the syringe sometimes you can push it faster without even knowing. And this one is very nice. It's very easy. Yes,
Okay, thank you for the video. So that's one of my nurses working on my medical board. I'm very passionate about feeding, so I'm very privileged to have her working with me. I think what you realize out of the video is the two ways of doing it, but for both ways, you need to have everything ready. So you need to have your water there, you need to have the syringe there, you need to have the feed available. Otherwise, you do need a second person to administer the protein boluses. My one ICU nurse, when we just started and you're trying to figure everything out, said she felt like an octopus because she felt like she didn't have enough hands. So you really need to streamline that whole procedure. And I think this is something that you do need to help your nurses with as well. Just to talk to them, it's like, how are you administering it? Can we maybe make it easier for you? Because the easier it is for them to administer, the more assured you are that they are actually going to administer that. So the advantages that I feel with using the ProSource Liquid Modular is that it's already mixed. So you can just administer it. They don't have to mix it beforehand. I think really during like COVID, it really does help to save some time. And my biggest thing why I actually use it is I can count the number of sachets that's left over every day. So I actually do know whether they're administering it or not. I think a lot of dietitians I've spoken to over the past months have actually also acknowledged and said that if you prescribe a powder feed in a tin, you do not know whether it gets administered every day. So that's a huge downfall or pitfall to using those products. So it's really a big benefit for me. Then considerations when using the ProSource is the administration time. So you really need to look at when are they going to administer it. So if you want to administer the sachet BD or TDS, or you can go up to 4 or 5 sachets a day if you feel it's necessary for your patient. Are you just going to write TDS, then they decide when they're going to do it, or does it in your unit mean that it's every 8 hours? So in my unit, it depends on the nurse. So for some nurses, it's every 8 hours. For other nurses, it's from morning to evening before they go off leave, off duty. That is the time span they've got to administer a TDS then. So you need to take that into consideration, talking to them and planning. Then also remember the additional water that you need with the flashing. So it really does contribute to the total fluid management for the day. And then lastly, as far as the interactions with medications, I don't think you should forget that. For example, your medications for hypothyroidism, like your altoxin, you actually need to take that on an empty stomach. So you need to time that with your protein administration. And then also you get interactions with some of the medical formulations as well. So some of the medications you cannot administer with, for example, this protein pulsing or the ProSource or any feed for that matter, because it's going to interact and that is then going to contribute to the medication not working effectively. So you really actually need to go do a proper assessment of all the medications the patient's on to decide when are you going to give it. Are you going to give it on empty stomach after they administered the medication, with the medication, which I would not recommend because most of them has got interactions. So my last question to the audience, I'm sorry, I'm running a few minutes over time, is who would consider changing the enteral feed administration at this moment? So remember, I'm doing this continuous semi-elemental feed along with the protein pulsing. So we would consider changing it to either cyclic feeding, intermittent feeding, or bolus feeding? Or are you going to continue with the continuous feeding and then just the protein pulses? And I'll give you a few minutes to just give an indication what you think would work or would be to the benefit of the patients. Well, this definitely, it seems like a clear winner, but let's just give it a few more seconds. Oh, it's changing. Okay, well, I do think we've got a good idea here now. So it seems that most of you feel you would start moving over to bolus feeding along with the protein bolus administration. And then some of you said you'll do continuous. So nobody is selecting cyclic or intermittent feeding. Can we maybe please move back to the presentation? Okay. So again, I think you need to consider the effect on the muscle protein synthesis. So remember that continuous feeding, you sort of get that they call it saturation. So maybe you don't have such effective muscle protein synthesis. Again, we don't have a lot of evidence for this. This really comes out of the sporting field. But we know Liesel Feltzman is doing a study with regards to this, but specifically with TPN and not enteral feeding. Intermittent and bolus will definitely have the maximum effect if you're going to only look at muscle protein synthesis. So McNally in 2020 conducted a study where they went to go look at the effect of continuous versus intermittent feeding. And what they actually found was intermittent feeding. So intermittent feeding, as you can see from the slide, very similar to bolus. You just run it over a bit of a longer period. So I must say this patient is now day 50 in my ICU. And she's still there, and we're doing intermittent for her. I've started moving her over to bolus now. So with the intermittent, they actually saw an improved protein intake, but no difference on muscle loss when they compared the two groups. Okay, so yes, it does seem to work, but you definitely need a bit more literature on the impact and the application of this. But, you know, I would agree with what the majority of you said, going over to a bolus feed, or then, like I said, I moved over to intermittent feedings for her. So really to get that muscle protein synthesis going. And we also know it's a bit more physiologically correct to actually feed a patient and then rest for a few hours and then feed the patient, because that's how the rest of us are eating. So this all sounds wonderful, right? And I know, like speaking to dietitians as well, everybody's, oh, no, it sounds exciting and they want to try this, but what about costs? So for those of you in private, but government is also cost-driven. But in private, we've actually seen that you can save some money by using the liquid modulars compared to using a very specialized formula, for example, like this very high protein to energy ratio feeds. So you can save up to probably about 33%. It's a few quick calculations that we've done. And then also looking at in-hospital, the majority of medical aids do cover it in hospital, but out of hospital, nutrition can assist with a motivational letter for PMB application if you would like to continue doing the protein boluses for a patient if they maybe, for example, go to step down or to rehabilitation. So my conclusion to today's presentation, Protein administration is a must, but you should consider the optimal intake timing. So how much to give and when to give it. In the early acute phase, we're definitely going for a bit of a lower protein intake versus the late acute phase where we really will start increasing it. And then compared to the chronic critical illness where it's really a lot higher than in any of the other phases, but you do need to consider the nutritional status of the patient. Then just a few tips on how to achieve optimal protein administration in your patients. You can look at that high protein or specifically actually the very high protein to energy ratio feeds. Then a second thing that one can consider is the overprescribing, because remember, you've got a lot of disruptions during the day's feeding. So actually consider prescribing a bit more because you know you're actually not going to get it. We've got the evidence from studies that things that's prescribed are actually not administered. Then to consider the modular protein boluses, which I like to do, and then also to do volume-based increases, which I'm not aware of any dietitians actually doing that in their units. But I would be interested to hear if somebody in the audience is doing that. So yet again, thank you for joining us, and thank you to Medtrition for the opportunity. And here's all my references.
Thank you so much, Vanessa, for the very insightful talk. It seems like everybody really enjoyed it. There is opportunity now for questions. So please post in the comment section if there's any questions from the audience. What we can maybe start off, Vanessa, what I'd like to ask you is, with the protein pulsing, in which patients would you say that is the most beneficial?
Okay, so I would definitely think where you're definitely going to see a benefit is in your obese patients, because we know we need to do hypercaloric feeding there. So definitely there, definitely I would feel in your malnourished patients, you do need to meet the energy, but we know the protein is very important. So I use it a lot in my medical patients and my obese patients. In my surgical patients, I think their tolerance can sometimes be a problem. So I do it a bit less there, except if I know that it's a few days in since admission and they're tolerating.
Okay.
And then, of course, sorry, the other one I can mention as well is I actually do it quite a bit in my patients with acute renal failure that's on CBVHD, because I've got such high protein requirements. So I've been doing protein pulsing there as well.
Yes, that actually leads to the other question that came through. That is, what is the impact of protein pulsing then on a patient's renal function?
Okay. So there isn't any studies done on the impact on the patient's renal function. I think the biggest thing is to take the protein pulsing as part of your requirements that you've calculated and not to do it as a top-up, specifically in your patients that's maybe got renal insufficiency or acute renal failure. So I would definitely include it in there. But what they've seen is there is an interesting study that they looked at the urea and creatinine levels with high protein intake, so not specifically pulsing. And they actually saw that, yes, it does increase the urea and creatinine level in patients in the ICU, but that increase in urea and creatinine does not affect outcome in the patients. So if you keep it within your calculated requirements, it ought not to have such a big effect on the outcomes of those patients.
Okay, that makes sense. Then we've got the question of, does an increase in just protein affect the protein absorption?
Okay, so again, probably not. What they do think is what happens is if you don't give enough protein, your splanchnic organ, so that's your gut and your liver, actually retains quite a bit of the protein that you administer. So it retains quite a huge fraction of the protein you're giving. So the more protein you're giving, the more protein is actually going to reach the systemic circulation, which will be beneficial to the patient. What they do think is that there's also, again, not a lot of studies on protein absorption in your critically ill patients. There's one or two where they hypothesize, or there's some evidence that the gastric absorption is affected and that it's better post-pyloric. But again, very minimal information on that. So I do not think just increasing the protein or doing the protein boluses will actually negatively influence the protein absorption. It will just actually be beneficial for the patient.
Okay. Then we've got a question in the Luyard et al. Study that you discussed. How did they measure muscle mass in critically ill patients? So they want to know what is a practical way that they can do it actually in their clinical setting if they're on a ventilator.
Okay, so in the Lloyd one, they did an ultrasound, which they did, and if I remember correctly, it was at the back. It was actually at the C3. What's a neck valve? The C3. What's it in English? A neck valve, Laura? Sorry, guys, I'm now blank.
Sorry, what is that?
A neck valve. What is it in English?
Vertebra.
Vertebra, thank you. So the C3 vertebra, they measured there, which I found quite interesting. But, you know, if you can look at the literature, most of the times they do ultrasound, but you need somebody, the same person doing it, because the interpretation is difficult. Yeah. So it's usually done with ultrasound.
Okay. Then we've got somebody asking your opinion on using a liquid modular, something like the TF3 we discussed, versus a powder for home care patients. So how would you decide?
Look, I think you need to discuss this with the care unit they're going to be at if they're not at home. If they're at home, you need to discuss with the family. And you'll probably have to consider the cost involved. Looking at both. I think, you know, I would assume, and again, this is a big assumption, that when they're at home, the people will more easily administer or more readily administer the protein boluses. So I think it will be more of a discussion with the caregivers. More than anything else, that will make me decide on what I will administer. But again, looking at the convenience, you know, so let's say somebody in home care that's on a PEG tube. I do think there's some convenience to using a liquid form, but then again, if you look at the powder form, you can always mix it into the feed and administer that. So yes.
Yeah, so it will all depend on the specific situation.
Yes.
Okay. Then we've got the question if there's any benefits of doing protein pulsing in COPD patients, especially after they're receiving physio.
Yes, definitely. So most of your studies that was done clinically on the effect of the amount of protein in a meal was actually done on COPD patients because there's such a high risk for malnutrition. So definitely, without a doubt. What I try to do in my unit is I've actually got my physios are very, very passionate about the multidisciplinary team as well. So I've actually got my physios, they'll actually come query with regards to what I'm giving a patient. And I've asked them, and they've been quite helpful after they're busy with a session with the patient to actually take the supplement, because they also get to know the supplements a bit, to actually take the supplement and give it to the patient and tell the patient, listen, you remember, you need to take your supplement after your physio session. Specifically if they maybe had a very long walk down the passage and the patient's extremely tired. So yeah, without a doubt, I would use it in COPD.
Yes, yes. Yeah, and it just goes to show the importance of everybody in the team working together.
Oh, definitely.
Huge difference.
Definitely. You need your nurses on board as well.
Yes. Latching onto that, Vanessa, there's a question as well is what would be your recommendation then for protein pulsing in the COPD patient? I don't know if that would be possible to answer that, or will it depend on the patient?
I must just go to the back of my brain with regards to the study. So what I would recommend, and I'm going to refer the person that did that question to one of the LLL courses. They've got one that's on lungs, and there they actually talk a lot about your COPD patients and administering protein. And your LLL course, you just go to the ESPN website, and there you'll see a link to the LLL website. And the registration is for free, so the online courses are for free. So I would really recommend just actually go register there, and then you can just go look at the course there. My apologies, I can't recall exactly, but it's very close to that 21 to 28 grams of protein that they need after a session of physical exercise, because the physio and the physical exercise is so tiring for them. they really need to take that protein pulse or the modular protein afterwards.
Okay. Thank you so much, Vanessa. I think we'll conclude the Q&A there just in terms of our time. We will now be moving over to the second part of our webinar, where you'll have opportunity to read a very interesting article by well-known Prof. Paul Wishmeyer. So the title is Tailoring Nutrition Therapy to Illness and Recovery, where they'll actually be discussing the Minnesota study that Vanessa also referred to in her presentation. So there will be 10 questions afterwards, but a lot of the questions Vanessa actually already addressed in her presentation. So her presentation will also be available as a link, so you can easily click there and get access to her presentation if you quickly want to go and have a look there as well. But otherwise then we've got an hour set out, so you can take your time, read through the study, answer the questions to obtain then 2 CPD points. And remember, for the 2 points, you need to obtain 70% for the test. But while everyone is still online and before everybody is starting to read the article, I would really just like to thank everyone for your time, for joining us this afternoon for this very insightful talk. If there's any questions or for Vanessa or to our team as well, or if you need more information, please feel free to reach out to myself. My details were on the invite as well, or to any other nutrition representatives, and we'll be in contact then after the webinar. But thank you so much, and I wish you a lovely afternoon further. For the ones that's going to complete the article, then please stay online and take your time to go through the study. All of the best then. Bye-bye. Hi, everyone. We realized that there's a bit of a technical issue when submitting the answers for the questionnaire. So we are busy working on it, and we will post in the comment section a new tool that you can use then to just answer the questions so that you can still get your CPD points. Otherwise, if you press for time, the link with the questions, everything will also be available until the end of the year. So if you'd like to do it, maybe tomorrow, then that is also perfectly fine. Sorry about that, and thank you so much for staying with us. Hi, everyone. For everyone that is still busy with the test, as soon as you submit, the test results will be available and sent to you the following day. So if you complete the test now, then I will send you your results by tomorrow. Otherwise, if you don't finish it now and you want to complete it at a later stage, then you will still get your CPD points for the rest of the year, and I will then send you a confirmation email with your results. All right, thank you so much, everyone. Have a lovely evening.